But it's my pleasure to introduce our speaker for this session, Sue Madge. And now I've got this bio here, and I've been told I'm not allowed to read it, so I won't. But I have had the pleasure of knowing Sue for a number of years, and she's one of the preeminent people in working in cystic fibrosis, and has had a long experience at working with people with cystic fibrosis in an adult service. And so I think it's really fitting here that the topic is adherence. How do we make them do what they have to? Now, I'd just like to say good luck with that, Sue, because there's no way that you'll get somebody to do what they have to do, but I'm sure you've got lots of good strategies to help the parents in the room this morning. So on that note, welcome Sue Madge.
Yeah, it's nice. I didn't choose the title, I hasten to add. Good morning. As Mitch said, I work with adults with cystic fibrosis, but I've only been doing that for about 11 years. Prior to that, for 20 years, I worked with children with cystic fibrosis. So this is a sort of mismatch of information that I've gained over the years from both working with children, parents, adults, and anyone else that's hanging around at the time. So I got given this title, and everyone at work said, that's a terrible title. You can't use that. That's not the way that we want to work. We want to work with people, not against them. But I quite like it after a lot of thought, because it is really against everything that we do. And it's a reminder that as healthcare professionals or as parents, it isn't really our job to make people do things they don't want to do in CF or in life or in anything. It's how to work with people to encourage people to do what they want to do, and hopefully with the right information, they want to do the things that you would like them to do. So these are the objectives of my talk. I want to talk about what adherence is, why it's important, why do we need to even be here talking about it, balance that out with the reality of life, and how communication works between you as parents, you as patients, our children with CF, and the healthcare professionals. And then how can we help, and not just me as a healthcare professional, but you as well, as a teamwork. So over the years that I've been working in CF, adherence has been called all sorts of things. You will do what I say you do, and people talk about compliance and non-compliance and adherence and non-adherence. And in the pharmaceutical industry particularly, they talk about concordance. And I guess, although it's another word to use, it's probably the most accurate, because concordance really means teamwork, involvement of the people that you're working with in coming together in discussion to come up with an answer and how things are going to be. So although we don't tend to use the word concordance, it's probably quite a useful one. So just talking about, because I will use adherence because that's what I'm used to, just talking about adherence and how we think about it as healthcare professionals and how parents think about it, how patients think about it, is ever so slightly different. But there's been loads of research over the years about it. And most of the researchers have found that there are different types of adherence to different treatments. So if you think quite logically, if you do something and there's an immediate result that's beneficial, you're more likely to do it. If you do something that's beneficial and you don't see the results for 20 years, you're less likely to do it. And that's not just in CF, that's in every aspect of our lives. So we're all supposed to exercise for something like 30 minutes 4 or 5 times a week, and how many people actually do that? We're supposed to drink in moderation, we're supposed to eat a healthy diet with 5 fruit or vegetables, whatever they are. And how often do we do it? We're given a course of antibiotics and you feel better after 5 days, you stop taking them. So it's the normal way of life to be non-adherent, because we all have free will and we all make up our own minds about what we're going to do. So a lot of this research has found, obviously, the same thing, that adherence is poor when you don't feel any benefit or the outcome is several years down the line. So in medication, adherence is generally quite good because people spot the difference often when they take things. Dietary, hit and miss, depending on how you feel. Nebulizers, those people that do nebulizers do them, and those that don't never do them. And it depends, particularly things like DNAs or hypertonic saline, where there's an immediate result. People tend to do them. Nebulized antibiotics, who knows whether you get feel a result or not, so they're less likely to be done. And physiotherapy or airway clearance, again, I think probably people that are sicker find relief and find it very helpful, but younger children, why bother? Never gets done. And that's the reality of it. And I've got some more data to show you further on down the line. So why is it important? Why do we keep going on and on and on and on about adherence? And I think it's because survival in CF is improving. I started working in CF about 30 years ago, and in the clinic I worked in, children's clinic, not everyone went on to adult care. In fact, only a few went on to adult care, and that's changed completely. So in the UK, there's about 9,000 adults and children with CF, and in the last few years, there's only on average been 3 childhood deaths from CF a year. So it really is no longer a life-limiting disease of childhood. It's a life-limiting disease of adulthood. And that is because of early and aggressive therapy and people like me banging on about adherence to actually do the treatment. So it is important because the evidence is out there. There's a huge increase in survival. But it means there's very complicated treatment regimes, and the more drugs are discovered, the more things we add to the treatment regime. So we need to take this on board. We need to think along with you as parents, along with you as patients, and with us, to find the best treatment regime. And that might be limiting things, it might be adding things, it might be taking things away, but it's something we always need to be conscious about and have a discussion. If you're unhappy, tell your healthcare professional, and if we're unhappy, believe me, we'll tell you. There's been also in the research a lot about how to measure adherence. I think actually it's probably one of the most impossible things to measure in the world, because unless you stick yourself side by side with someone to see what they're doing every minute of the day, you're never going to know. But the least reliable is patient report, because we always have an inaccurate idea about what we do, whether you've got CF or not. We tend to overestimate what we do. So there's been quite a lot of research asking people about their exercise, not people with CF, just general people. And everyone thinks they do far more than they actually do. And I think that holds true with a lot of research in CF, where people report that they do all sorts of things, and in actual fact they don't. So moving down this list, at the bottom, the electronic monitoring, there are some nebulizers that you can get that have got little chips in them that can be downloaded, and then you can see how long the nebulizer's been used for and how often. And there are some people who really believe that they're doing it twice a day, every day, and when you download the chip, it's not happening at all. Then there are some people who do it far more than they're even asked to. There's some graphs around and some papers about people doing it 5 or 6 times a day for some odd reason. But on the whole, we over-report. As human beings, we tend to over-report. Then there are clinical assessments, also not that terribly reliable. Then there's looking at how many prescriptions are being dispensed. So some researchers, particularly in the States, have access to the prescriptions at your family doctor and how many times that's been picked up. And they feel is a good, accurate way of finding out how many drugs have been taken. But that only measures drugs, doesn't it? It doesn't measure everything else. There are bottles you can get with little clicky counter things on the lid, so every time it's opened, it counts. But again, that's not terribly reliable, because anyone that likes a nice clicky bottle will just open and shut it. You can, probably the most accurate way is to measure the levels of the drug in the blood or the urine. But again, that's just measuring drug adherence, that's not measuring anything else. And then the covert, so some monitoring, some of these chips inside nebulizers the patients know about, and some they don't, which is a little dodgy area we won't go down. So we've measured, we think we know what's going on, we know it's not terribly accurate, and we know that as healthcare professionals there's a lot of treatment that isn't being done. Now some people leave it at that and feel that their whole role in life is to make people do what they don't want to do necessarily, but then there's entering into discussion with you as patients or you as parents to find out what actually goes on in people's lives and how CF fits around it, because actually life is quite busy. So we know that, and I've done research and looked at parents and the parenting role and how that changes. And those of you who are parents in the audience will know that as well as being a parent, you also take on the role of maybe the doctor or the nurse or the physio or the dietitian, and that can be quite tricky in a parenting role to know where the boundaries are and what you're doing. And that's quite hard to make sure that treatments are being done, because as a parent you don't want to do anything to upset your child, but maybe as the doctor you want to make sure that your child has the medicine. Adolescents rebel, whether they've got CF or not. All adolescents rebel. It's just that when they've got CF, they can make it really, really difficult for you as parents and for us as healthcare professionals, because they've got something that will really upset both of us by rebelling against. So by not doing their airway clearance or not taking their treatment or not going to clinic or refusing to do everything, they manage to wind up a huge percentage of the population, and it works really well. And as adults with CF, quite honestly, there's life. And CF has to fit in round life. And now I work with adults, I get told this quite a lot. So when I see a patient in clinic and I want to talk about a new treatment, we have to talk about a daily routine and how that's going to fit into getting up, going to work, travelling to work, travelling home from work, cooking dinner, going shopping, going to the pub. Where does the treatment actually fit into all of that? So it is quite complicated, and life should probably play an equal role to CF treatment. So for parents, it is very much. And, stand up and tell me if you want to make any comments. It doesn't have to be me doing all the talking. It's treatment and the necessity to do the treatment versus your daily lives. And for most people, being a parent isn't an isolated bubble thing where you just have your child with CF or maybe two, and that's all there is to life. You may have other children. You may also be caring for your parents or your neighbours or your job. So there's a lot more than just caring for a child with CF. And then there's all these other things that you have to do to keep your child well, to get them to adult life, and trying to work with, which is not always easy, your growing child, to take all that on board. And then there's that tricky thing about giving children independence, and you give your child independence because you teach them how to clean their teeth and expect them to get on and clean their teeth, but do you do that with airway clearance? Do you do that with taking their pancreatic enzymes before they eat? It's quite hard to know that line about allowing independence in some things but not in other things. Teenagers always tell us that CF treatment is boring, and there's quite a lot of research that also tells us that, and they don't want to be different from their friends, and if their friends don't do treatment, why should they? Sometimes, and working in adults now, I wasn't aware perhaps of when I worked in children, but sometimes parents are so keen to make sure the treatment gets done and done properly that their child never ever learns to do it. So I see a 17-year-old boy in clinic who hasn't got a clue what drugs he takes, or what they're for, or how many, or what their names are, because his parents have really, really worked hard to make sure he gets to 17 and is really, really healthy. And to do that takes charge. Unfortunately, they go to university and they can't cook because no one's ever taught them to cook because their parents are always doing the cooking. They can't shop. They don't know what drugs they're on. So all they do is go to university, drink beer, and get sick. We have a lot of university-age kids who can't do anything for themselves. We're then having to help them along the way. They will do treatments that are effective. So Creon, pancreatic enzymes, is pretty good because you get tummy ache if you don't take it. There's been a lot of research to show that as you get older, you get worse at doing things. Not just if you've got CF, it's just a matter of life. I guess you learn to take risks and are more comfortable with the risks you take. So the research has shown that the excuses given for not doing physiotherapy, for example, is not enough time, too much in the life, or you feel too well. Why do it when you feel really well? And a lot of, particularly adults, don't take medication because they don't think they need it. And if you're given the information and it's an informed choice that you're making, who are we to necessarily say that they do? But again, it's giving the information and making an informed decision. So in adult life with CF, there's not enough time. There's not enough time in our days, often, is there, for just the things we want to do. So can you imagine putting all the sort of treatment we ask them to do as well? People forget. You think, how can you forget to do something that you've been doing every single day of your life and you know it is helpful to you, people still forget. I have to take medication every single day of my life. I forget all the time. And we're too busy. We've got a lot to do in our lives. A lot of people, the research is showing us, don't do things if they think they're well enough. Despite the healthcare professionals saying you need to take this because the research shows that it's got to have a certain level in your blood and that level's got to stay continuously. If you don't feel well, if you don't feel sick, don't take it. Forget to renew prescriptions. I see a lot of patients in clinic who run out of drugs and haven't renewed the prescriptions. Some it's just a couple of days, some it's just a couple of months. I do wonder what they're thinking about. And some people are just too busy. There are other commitments in their lives. It might be their children, it might be work commitments, and work commitments are very important in this day and age. It's hard to get a job. If you've got a job and you're keeping it, you probably do have to concentrate on that rather than anything else. So this is a study, and there are similar studies to it, which questions were asked of adults with CF, why they didn't do treatment or physiotherapy. So quite a lot forgot, too busy, doing something else, feeling very healthy, so don't see the point, and run out. Why I didn't do physio? Because I feel healthy, too busy, doing something else, forget, and use exercise. Exercise is pretty good, but I'm sure if you have listened to Penny talk this morning, it isn't the only thing. You need to do other forms of airway clearance along with the exercise. So the reality of daily life, we have to acknowledge as healthcare professionals that surprisingly our patients have lives and we have to work around that, and that there are competing responsibilities. We're just fighting a little battle for CF, but there are a lot of other competing responsibilities that we have to fit in with and not have too high expectations of what we were asking people to do. Oops. So just to maybe take it down a level and look at what some of these realities of daily life are, particularly for our older teenagers or adults with CF, is there's a lot of tablets to take. And some of that is interrupted by work or school, and some people have to take it to work or school with them, and sometimes that can be very uncomfortable or doesn't get done because of having to do it in front of other people or not finding somewhere private to do it. Although when I worked with children, there was a girl who could put all her medication in her hand, and that was about 15 or 16 different tablets, put it all in her mouth and drink it down with one sip of water, and it became her party piece. And she would do it in front of the whole school if they wanted to watch. So, you know, it's how you view things sometimes, isn't it? Nebulizers take a lot of time and take a lot of cleaning, and probably easier not to do it than go through all of that palaver. Enzymes with food, particularly when you want to go out with friends and you haven't got your enzymes with you, it's a bit of a decision. Do you go out and have a good time and end up not with any enzymes, or do you say no and go home, or go home and get the enzymes and late? There's a lot of taking away the spontaneity of life, having to think of medication. And then oxygen. As people get sicker, they do need oxygen, and we have a lot of young people who refuse. We have some older ones that do, because it's differentiating. It means you go out. There are some young girls that we were trying to persuade that they really needed oxygen. She said, no, I'm not wearing it because I can't go clubbing with oxygen on. How will I ever get a boyfriend when I go clubbing wearing oxygen? And for her, that was paramount. For us, the oxygen was paramount. It took a lot of time for us to work out ways of doing this. So we decided in the end that for the afternoon before she went clubbing, she would sit still with the oxygen on, hopefully oxygenate, feel stronger, feel able to get up and around, go out clubbing for a couple of hours without the oxygen, come home, put the oxygen back on. So there's compromises. Life isn't absolutes. Life is always compromise, and with discussion you can usually get round most things. So when people miss all sorts of treatment, not just taking tablets, it's sometimes not because they just choose not to do it or forget. It could be too complex. Quite difficult instructions to take some things, particularly some of the nebulizers, setting up the nebulizers. And as I said earlier, if you don't feel any benefit, it's very difficult to persuade yourself to do it. Sometimes it's just not understanding the instructions. Do you do it before physio, after physio? How do you put the whole thing together? Feel too well? denial. Denial is a fantastic coping mechanism. If you work in psychology, psychologists encourage sometimes denial because it helps people get through in all different aspects of life and not just CF. But it also can be harmful. And a lack of understanding, as I said, do you do it before physio, after physio, what's the dose? Is it just for a short course? Is it forever? And we have a lot of patients that think they're on a short course of antibiotics and we want them to take them forever, or a short course of something, and they stop after 2 weeks and never continue it. So it's us, we haven't explained it properly. And life, frankly, is too interesting, particularly for teenagers. And as you can see, there's been a lot of research looking at this. And it's the same old thing. It's lack of time, it's forgetting, it's doing things in public, so differentiating yourself, looking different, forgetting, being too busy, unintentional forgetting, and then sometimes just knowing what you're doing. Doing CF treatment intrudes into freedom, and sometimes treatment regimes are manipulated to fit into life, and sometimes we wonder whether that's wrong. We don't really know how much non-adherence or how much adherence is enough. Perhaps you don't need to be 100% adherent to get the benefit from the drugs. We only know from the science behind it of what should work. But for some, we're all different, and it may affect us all differently. And who's to say that if you do it every other day, it's not the wrong thing to do? So that's a whole other part of research that as healthcare professionals we should be looking at is 100% isn't necessarily right for everyone, and we should be looking at individuals and finding out what's right for individuals. I think there's also a big drive, just this final point, that if we give people enough teaching and enough information, they'll know why they have to do it and do it. And that's so not true. Whether you've got CF or not, none of us follow that rule, that we can have as much knowledge as we want, but still choose not to do it. And that's intentional non-adherence. So it's all about communication. We all need to make these decisions together. It shouldn't be one person or the other making the decisions. And we have to ask ourselves, and perhaps you have to ask yourself, do you really know what's happening? And who asks the questions and who gives the answers? So I know that some of our patients will tell the doctors one thing and the clinical nurse specialist something else. What they perhaps haven't thought through is that those two people talk to each other and wonder what the difference is and then go back and find out. But it isn't necessarily that there's going to be the same story for everyone, so we do have to work things out a bit. I think also none of us want to appear unreliable or appear we're letting people down. So we all, to some degree, come up with a story we think the person listening to us wants to hear. And a lot of the time that's okay, but sometimes there are key things that we probably do really need to know about. And there's an engagement in treatment. We need to make sure that we put the situation, the education, the right surroundings around for our patient group to allow them to start doing things. And if they choose not to, fine, but we need to make it as available as possible. So we are very keen on this whole involvement thing, which I keep going on and on about, I know. So we discuss everything and choose not to do some things if the discussions go certain ways. We're conscious that we shouldn't keep adding things, however great they are, and new drugs just come out. We have to sit down and look at what everyone's already on, what we can take away before we add something new. We try and work through the timing of the day, as I said. What time do you get up? What time do you have breakfast? What time do you do your other treatments? How's this going to fit in? How long does it take? So think about lifestyle and negotiate. We do have to negotiate because it's the fair way of doing things, and it's much better to do 3 things perfectly than 12 things badly. And so we do sometimes have people on less than we would like, but at least we know that things are being done properly rather than being very haphazard and not being done at all. Part of this negotiation is collaboration. I think working together with whoever, the adult, the teenager, the young child, the parents, helps us have that relationship and some trust and some honesty, because if it's much more helpful if someone comes to clinic and is really, really sick and tells us they're really, really sick because they haven't been doing any treatment for a week, than come to clinic really, really sick and say, well, I've been doing everything, because then we just add more. When in actual fact, all we have to do is say, we'll start doing these things that you've got at home. So it's helpful to both of us. And setting small goals, as I said, do one or two things really well, rather than not succeed with anything. So if we've got a young girl at the moment who's just transitioned from paediatric care, who did badly at everything, so we've stopped all treatment. And we've said, go home for a couple of weeks doing nothing. And then when you come to clinic, we'll choose one thing that we really want you to do and see if that helps. So we're just going to build up one thing at a time and find out what's most helpful for that young girl to help her get a handle on things and start going again. But finally, we do have to respect patient choice. We have to respect individual choice. We are all individuals, you and me, and we choose what we want to do in our lives. And if I make a decision to do or not to do something, I hope people respect that. And likewise, we should all be doing the same thing around treatment. So how can we help? Us as healthcare professionals, you as patients, you as parents, we all need to collaborate. We need to acknowledge the barriers. What stops people managing to carry out treatment regimes? There's people's personal health beliefs. I've got a sister-in-law who drives me nuts because she believes that all doctors are out to poison her and her children, and that's her personal health belief. She won't accept medication from anyone, and she uses other things. But it's her personal health belief. There's little I can do about it. Knowledge. Now, I said before that a lot of knowledge doesn't necessarily mean that people will do things, but it helps with making decisions. As adherence to all sorts of things in life change and go down sometimes, decrease, with all sorts of different things, and not just CF. So as you get older, you get worse at doing things, perhaps. Dare I say it, males perhaps aren't as good as females at doing some things. Socioeconomic status, obviously. How long since you were diagnosed with something, not just CF, all diseases, the longer you are away from diagnosis, the less you're inclined to do the treatment. Levels of functional impairment. We do have to recognise that not all of our patients have an IQ of 200. Some have psychiatric illness, some have physical problems that you can't get the lid off the bottle. We have to think about all these very practical things and whether there's anything else going on in people's lives also influence adherence. Also is the behaviour of the healthcare professional towards the family or the patient. It has a huge implication on adherence, and I think that that's something that we can all work on together to make sure that isn't a problem. So the interaction with the healthcare professional. What we're asking people to do, 600 nebulizers a day, we acknowledge that they'll never get done. What's going on in the family? Are there 10 children, one of them with CF? There's also expectations that things won't happen. The way people cope. Different family things. And again, this is basic adherence in the general population. This isn't necessarily specific to cystic fibrosis, but you can see just from the list how it can impact perhaps on some way some treatments get done. So there are psychologists and psychiatrists that have, of course, worked everything out and worked and described non-adherence to treatment in different ways. So there's what's called psychosocial resistance, where it's really things that are going on in people's lives. So psychopathology, whether you have a psychiatric illness, whether you have very disorganized home life, peer group pressure, your own autonomy and control, and your own, like my sister-in-law, personal health beliefs. Then there's educated non-adherence, which for healthcare professionals is very difficult to deal with, because it's where individuals make an informed choice, fully understanding the consequences, not to do something. And we often struggle with patients who, quite rightly, decide that they don't want to do something if we told them all the reasons why. And it's quite hard watching someone get sicker and sicker and sicker, knowing that they know what they need to do to stop that happening. And I guess out of all the different forms of non-adherence for healthcare professionals, I guess also for parents, particularly of teenagers, that can be the most frustrating to deal with. And then there's just inadequate knowledge of what's happening and how it all works together. So we work in partnership. thinking about treatment goals. And as I said, with this young girl recently transitioned, we've got very small, very specific treatment goals, but hopefully we'll move forward with that. We have to work out what are personal goals, social goals, educational goals, because they're also just as important, and put them on a straight line along with our treatment goals and see how they all fit in together. What are the requirements? What are we asking people to do? Then say and rule out those things that get done really easily, not a problem, fine, put them to the back and put them to the side. Let's concentrate on the things that cause a problem. So we try sometimes to think about the things that cause a problem in a sort of brainstorming way and say, what would happen, what would need to happen to get you to do this? And it can be as mad as you like. And we put all the ideas down and then filter them. So a holiday in Barbados every time I do my nebulizers is probably not going to happen. But maybe if you're 5 or 6 and a trip out at the end of a month of doing everything will happen. I don't know whether I should say this, but I'll say it anyway. So we had an adult, a 45-year-old man who was married, and his suggestions for helping him do things, his wife said to me that if he didn't do physio for a week, then there was no sex for a month. And she found that worked really well. But it's not something that I can perhaps persuade all the patients to get down with. So I have to filter down to what's realistic and what isn't, and then get them to try it all out. Try out these new plans, try out the way of doing things, because often you will be able to hit on something that works. And I don't know whether incentivizes is a word, but I think ownership incentivizes. So if I sit with someone and work out all these different strategies, and I come up with the strategies, not going to happen. But if they come up with the strategies, it's more likely to happen. So ownership is a great thing and shouldn't be someone telling someone else what they have to do. So there are different, talking about strategies, ways of trying to help people, and we're all different. And so we need a lot of different strategies to try and find the best one to suit us for whatever reason we have to do something. So in healthcare, there's this collaborative approach to care where the clinician and the patient work together and come up with the answer. And then some of you may have heard of motivational interviewing. I'll tell you all about these little ones in a minute. Cognitive behavioural therapy, very popular, CBT, problem-solving therapy, personal construct psychotherapy, and then direct intervention, which is usually peer intervention. And they're quite useful, and not everything is good for everybody, but there may be something that's good for an individual. So we try and think about them all with our patient group. So collaborative approach is generally what you can see. It's where you work together with the healthcare professional, thinking about how to be flexible, how to find the right things that work, and then try and get on with it. Motivational interviewing is usually done by psychologists, but not necessarily. Anyone can train to do it, and in the UK, a lot of physios, dietitians, and nurses also do it. And it's to try and not say you've got to do something, but to sort of establish a conversation about how things can be done. And then work out with the individual why things aren't done. When you know that should be done and it isn't getting done, where's the discrepancy? What's holding that back? And then try and work with those in little steps to work out how to move that forward. So as it says in the name, it's motivating. It's motivating to get by those discrepancies and someone working that out for themselves rather than being told. Problem-solving therapy can be quite useful, although it's sometimes a bit airy-fairy and doesn't get anywhere. So it's helping individuals. It's all of these are helping individuals make the decisions themselves, rather than the title of my talk is me making someone do something because they've got to do it. So problem-solving therapy is an individual trying to work out what the negative impact of something not being done. And that way you can help people cope with the situation a bit more. And once individuals, whether they've got CF or not, understand why they're not doing something, it sort of helps in the future to keep going with things. For some people that works perfectly and is a really good way of getting around treatment, but I've found that on the whole it doesn't seem to help much the majority. CBT, you will have all heard of this. It's something that's used in psychology a lot for all sorts of different problems, particularly depression, because it helps people look at things calmly and step by step move forward. So it's, as it says here, it challenges the negative thoughts. So I don't do physio because, why not? Why do you think that is? And then step by step building that up and working through and turning things round. So it's, as you see, it's building behaviour modification, which is a big psychological term, but it's really just helping people think through the way they do things, and gradually, stepwise, working out how to do things, practicing it, and then coming back and talking about it the next time, and then planning the next move. It may not sound very much the way I'm talking about it, but it's incredibly helpful. And if there are problems, we use it quite a lot for some of our patients, just to get around problems with treatment or get around problems with learning to live with CF and how difficult it is, particularly if it's 17 or 18. It's really tricky, and using something like CBT can be helpful with that. Then there are some more esoteric psychiatric things like personal construct psychotherapy. And I think one of the best parts of this, so there's a lot of it it's quite complicated, but one of the best things is, and I perhaps pick bits out of this to use with people, is this third-person characterization, is to say to someone, if someone described you, if your best friend described you to me, how would they describe you? And then use that to then say, so your best friend would say that you would do your airway clearance, and that's really helpful. It makes people see things through a different light sometimes. And also helps them realise that you are who you are, and that if you've got CF, that's part of you. It's not something separate, and learning to make that part of you in the way that you move forward with treatment. And it's little bits of this is usually quite helpful. So if any of you have worked with psychologists in your CF teams, think about asking about different things if you're particularly struggling, or children particularly struggling with different aspects of CF. And then something that I've started, sorry, I just have to have a quick bit of my coffee. Mainly because Mitch bought it, I can't waste it. Is this direct intervention, peer support. So, for example, we've got a girl who's incredibly bright, and she's at a really high-class university doing engineering. And very difficult to speak to because she speaks a language I can hardly understand, but she's completely rubbish at doing treatment, and she knows it. And she'll come to clinic, and I'll waste my time saying, so what are you doing? And she says nothing, and there we are. So we've got struck on this direct intervention. And we've tried millions of things, quite a lot of what I've talked to you about, but this seems to be working for her. So she shares a flat with 4 other girls. And each of those girls has taken one aspect of her treatment, and they've taken responsibility for it. And they don't nag her, but when they're around in the flat together or around the university together, they'll just mention to her their aspect of responsibility. So how's your airway clearance going? For some reason, it works much better coming from them than it does from her parents or her siblings or us. And she said when they get back to the flat in the evening or they're making dinner, and they won't make a big deal of it, so they sit down to dinner and the person responsible for enzymes will go, oh, where's the Creon gone? Something like that. And she's getting much better and more healthy and happier, and I'm a great advocate of this now. It can be done with children as well, where siblings can take a little bit of responsibility, or parents aren't responsible for the whole thing but just do one thing. And I think that sometimes other people saying things has a much better effect than the same old people saying the same thing over and over again. So, I urge you to give it a go if you're stuck with everything else. I just wanted to put this in as a warning. There are a lot of high-cost drugs becoming available to us, and ivacaftor is one of them. You will have heard of it. It's the new pill that's available for people with a very rare mutation G551D. Costs huge amounts, so much so that the regulatory bodies in the UK have given us quite strict instructions of how we're allowed to use it. So there's no doubt about it, it's a fantastic drug and it has changed the lives of our patients that are on it. But adherence, the people with the money are being very strict about adherence. So they are not allowed to pick it up from anywhere. It has to be delivered to their house by an approved delivery company. They are only allowed to have 1 month's delivery at a time, so that it doesn't get stockpiled if they don't take it. And the person that delivers it, the company deliver it, check to see that what they delivered last month has been taken. If it's not, then they have to report back to us as the healthcare professionals. And this is nothing to do with health making these rules. This is the government with the money making these rules. The effect of the drug normalizes people's sweat test results so they're in normal levels. So we have to do sweat tests on everybody before we start it to see what their CF sweat result is. And then we have to do it, as you can see, at different times once they're on the treatment, because again, that's a way of seeing whether it's been taken. So if you are taking it and your sweat test doesn't change, it means you're not taking it. So again, there are warnings, as you can see. If there's no change, find out why. If there is a problem, retest, do another sweat test. However, if the sweat tests don't change, we have to take the drug off them, which is a huge thing because it does change lives. And this is one reason why that girl I told you about just now with the friends helping, why we had to do that, because she wasn't doing any treatment, but she was eligible for this drug. And if she didn't take it, then we'd have to take it away from her. So we had to start working really seriously and thinking with her a way of getting around her non-adherence to treatment, because we really felt strongly that she would benefit from taking this drug. And for the first month she didn't. We gave it to her and she didn't take it. And we redid her sweat test and it was the same as before she started it. So we had to sit down and say, somehow or other we've got to get round this problem, because this is going to change your life. But if you don't take it, we have to take it away from you. It's not up to us. We have to take it away from you. So I'm just putting this in as a warning, because this is the first high-cost drug where other people other than us are making the rules about how we can give it. And I'm sure it's not going to be the last, because there are going to be a lot of new drugs coming along that are going to cost a lot of money, that other people are going to be dictating their use. So looking at how other ways, rather than psychological or practical, we can help people with treatment. So just to give you an indication, this is a snapshot of adults in the UK from the last registry data. So 70% of adults with CF in the UK are either work and study. And I've just put this up to show you that 70% of the adult population have lives and doing a lot of things, and we're still asking them to do a lot of treatment. So it's getting round that treatment versus life problem. So we need to think of other things to help get treatment done, and some of the smart technologies are going to be helpful for us. So there's telemedicine, which I'm sure you're all familiar with, and we do telephone clinics, and we're thinking of using Skype, although I don't want to do it myself, but I'm sure other people will. And it's helpful that we do talk to people on the telephone, but you can't really assess them when they're talking or looking at breathing patterns, and I think face-to-face is going to be much more useful. Smartphones are going to be fantastic, and we will be able to, and do now by texting, have a lot of contact with our patients through email and text than we ever did before, and rather than speaking or coming to clinic. And I think that's a way of the future, is just helping people with their treatment without having to bring them to clinic or seeing them. So home monitoring will fit into daily life, because everyone uses their phones for all sorts of things. I ran a marathon, did a triathlon earlier this year, and I was addicted to my app on my phone, my Tri app, and what I was eating and how much exercise I was doing, how long it was taking me. Since I stopped doing it, I've done absolutely nothing. But at the time, it was brilliant. So it'll relieve people that have to do long distances. And things like apps can be quite good for reminders and tracking. So looking at your lung function over months, or your weight over months, or how often you've been doing nebulizers over months. And I'm quite technologically challenged, but I am working with people to build an app for our patient group that they will be able to put all their drugs on, for example, and if the drugs are running low, somehow or other, some magic that happens with these people that are making it, it will alert the GP to do a repeat script so they can pick up the drugs. So no more excuses about running out of drugs, I feel. It will also be able to, if you choose to use it, track how many times you've done something and how often you've done something. And sometimes that's quite helpful to individuals, as I find. Coming to hospital, sometimes people are too sick, which seems a bit of a bizarre thing. In fact, that's a conversation I had the other day, is sometimes when you feel really, really rough, the last thing you want to do is go to hospital, but we're using smart technologies to perhaps get round that a bit. Although there is always a place for face-to-face consultations, so I think that it has to be a balance. So I think in the world of adherence or non-adherence, we have a generation of young people coming up that will be doing things that are beyond my capable of understanding in the future, and we need to start moving forward as healthcare professionals, as patients, as parents, to try and keep up with the technology to help us. So our children and young adults of today are going to access healthcare in a very different way to what's been traditionally happening, and we need to be able to do that. We need to think more about texting. We've discovered texting, I know a bit late, how wonderful it is to keep in contact with some of our teenagers. We thought we were really up to date when we started emailing them, but they chose not to read the emails. But they always have their phones on them, so they can't actually get away with not looking at the text. So we've got much better communication just through texting at the moment. So I think the future of healthcare is changing, but I think the future of the way that we can work together and us as healthcare professionals can help is also changing, and it may be along the lines of some of this smart technology. And I think that's it. Thank you very much.
Perfectly timed.
Oh, I know.
And now you can't run away though, because there is an opportunity for questions. There's a microphone over here. If anybody does have any questions for Sue. If there's a microphone just here, if you want to come and use that. Better to come to the microphone than running around, I think.
I was hoping there'd be more about adherence in small children, because we do have to make them do what they don't want to do, and where we draw the line, and so on and so on. Have you got any thoughts on that?
Yes, lots, but I think it is a struggle, I agree, and it's part of bringing up children as well, as all children have to do things that they don't want to do and their parents want them to do, and it's normalising, it's trying to normalise. But I completely agree, it is a struggle. If a child doesn't want to take a medicine, they won't take the medicine. But I think, work with your CF team to find ways of helping your individual child. I don't think there's any answer, because all children are different and will accept different things, and it could be star charts or things like that, or it could be there's a psychologist in America who has some great ways of teaching children to take medication, and using different sized sweeties and things like that to encourage them to learn to take tablets early. So it's exploring lots of different things. But I don't disagree with you. It's really, really hard, but I think it's quite useful to work maybe with the physiotherapist. Just try and make an appointment to spend an hour working, finding a way. There's lots of different airway clearance techniques, and maybe there are different ones that will work with your child. There are lots of different ways now of administering some medications, so find one that works. But at the end of the day, like bringing up all children, sometimes you do have to make them do what they don't want to do. I know that's not a great answer, but sometimes in life there aren't any great answers, and sometimes you just have to do things. If there was a magic bullet or an easy way to do it, we'd all be doing it by now. Sorry.
What age do you think you should let kids do their own nebulised antibiotics and stuff? So you talked about the importance of them being kind of autonomous and not dependent on their parents.
I think it's a slow thing, and no child is the right age for it. There isn't a rule that all children by the age of 13, but by starting early and giving them responsibility for different things. So even if it's for getting it out and laying it out, can be the first stage of the responsibility, then maybe mixing the powder and the whatever together, the next stage. And then it's up to you and your child. I think waiting, not doing it until they're just about to move to an adult hospital is wrong, because then, as I say, we get young kids in 16 or 17 haven't got a clue what they're supposed to be doing, and it's at a time they want to leave home, all sorts of things. It's essential, but it's also important to teach them how to shop and buy stuff with high calories in, which they can't do, or cook. So yes, nebulizers, but there's a lot of aspects to life that they need to learn and grow up. The other thing to remember, I guess, is that none of us live independent lives. We live interdependent lives. So you might be married, or you might, like the girl I was talking about, live in a flat with other people. So you don't have to do everything yourself. It's learning just to take responsibility, to be able to share doing things by yourself. So I guess we need to ensure that children growing up know how to do things, but also how to share and get other people to help them to do things. We don't expect patients to come to hospital by themselves once they move to adult care. They may want to bring their parents, they may want to bring their flatmate, they may want to bring their boyfriend or girlfriend. So it used to be believed that you got to adulthood, you did everything by yourself, but I don't think that's true. But we have to teach our children to become independent adults, basically, and part of that is, like I said, teaching them to clean their teeth. When do you feel that you can trust them to clean their teeth properly so that you never have to remind them and check that they've done it? It's that same sort of thing. It's a life skill that you're introducing.
Hello. I think I might be a little bit off topic, but something that nobody ever seems to want to talk about is this concept of institutionalisation in children that spend a lot of time in hospital, and the problems that sort of brings. So I'm experiencing that myself. My daughter spends about 50% of her time in hospital, and one of the things that we're facing is that normal teenage rebellion that comes along, the normal resistance, but the staff at the hospital she views as more family members, and so they're having real adherence problems there as well, where the staff aren't actually able to get her to do things that they could get her to do 6 months ago. So while we can introduce a lot of these techniques at home and strategies to deal with that, there seems to be a whole nother level of difficulty in getting those strategies implemented in, for example, children's wards.
Having worked in paediatrics for 20 years, I do have some idea about what you're talking about, but one of the strategies that we used to engage with children who are in hospital a long time was to sit down with the parents and the child, if they're old enough, and introduce the strategies that you'd want to introduce at home, and to make sure that even if every other child on the ward didn't adopt those strategies, but for that particular child, we tried to do what the parents wanted us to do to bring them up the way they would at home. The other thing I would ask your hospital is, what could you do at home so they didn't have to be in hospital as much? Even if it's for half a day, or, gradually lessen that time in hospital.
Sure.
So that you can...
We've certainly got clinicians that do try to do everything that they can do to make that happen. But I guess I'm just talking more about the personal relationships and her perception of those relationships, because she doesn't see them as health professionals and herself as, a patient, but she sees it as a second home, a family model. So you're getting more like things like back chat, things that you wouldn't normally expect.
I don't think that's your child's problem. I think it's the staff in the hospital's problem, and perhaps they need to look at boundaries and the way that they treat people, their patients. And it happens everywhere, that there's a bit of a blurring of boundaries, and people forget that there is a professional and a patient relationship, and some people think that they're all friends and they can be treated equally, and that makes it difficult for individuals, and it makes it difficult to treat patients sometimes when that boundary is blurred. So I would encourage you to ask to sit down with the team and talk about how you can resolve this. But I would also see if there are things that you and your daughter can do at home that she doesn't need to be in hospital for as much.
Yes, thank you very much.
Can I ask a question? So just what you were talking, obviously the thing with adherence and going on, I think, from the getting people to do things for themselves and learning those things. So what impact do you think that actually has then on adherence as you go along if you're actually taking those responsibilities earlier? Or don't you? Yeah.
Do you mean that learning something
Does it
from
help?
earlier?
Does it help adherence if people are actually starting to get more responsibility for their own healthcare at a younger age? Does that actually? Do you think that is a potential to help, or is it actually the opposite way? Because okay, now I understand all those things. I'm going to stop doing it earlier.
I think that the mistake that many of us make as healthcare professionals is that we think it's too black and white, and that there's adherence and non-adherence, when in actual fact we're all human beings and we do things differently, and we have different stages of our life. So we might be adherent for a little bit in everything, exercise, whatever, and then fall down badly for another part of your life. So it's also stages, life cycles, whatever, and things that are going on in your life, different competing needs. So I don't think we can expect 100% of adherence 100% of the time. I think what we have to do is make it realistic for as much of the time as is possible. I think learning things is good because at least you have it in the back of your mind. You might learn to ride a bicycle when you're a child and never ride it again, but there might become a point where it's quite useful to know how to do it. So I think learning how to do your nebulizers from an early age is good because it's just there ingrained, and you may, when you're 17, 18, 19, decide never to do another nebulizer again. When you're in your mid-20s, think, actually, that's quite a good idea, so you know what you're doing. So I think the trouble is everyone thinks it's a be-all and end-all, but it's like a long pathway of life where things happen. But as long as we all work together, we can try and make that less rocky. It will never go away. None of us, it's not within our human nature to be 100% adherent to everything we're supposed to do all of the time. What we need to aim for, you and us, is to try and get there as best as we can for periods of time as long as we can. And that's just sort of life, really, isn't it?
Questions? No. Look, there you go. Well, thank you very much, Sue, for that presentation. I think this is something that having had a slight experience of CF, slight experience of adherence, non-adherence, bloody-mindedness, all sorts of things along the way, I think it's good to actually touch base and recognise that sometimes we beat ourselves up about whether we adhere or don't adhere, and in fact we've got to recognise that that's part of life and that we need to aim to do the best we can as opposed to being perfect. So thank you very much.